Hi, Simon Smale, gastroenterologist at GI.healthcare. This is the second of the videos I'm doing on irritable bowel syndrome, and today I'm going to talk about making the diagnosis of irritable bowel syndrome. So it starts always with the story. So in terms of the story for irritable bowel syndrome, all patients should have a story that includes abdominal pain or discomfort and change in bowel habit, and that might be diarrhea, that might be constipation, or it might be alternating between the two. But they must have both those things, abdominal pain and change in bowel habit. Many patients also have bloating, other symptoms such as fatigue, brain fog, lethargy. They are very common. Anxiety is also common, often driven by the symptoms relating to the bowels. Now, the other thing I would say is that people should have the absence of what are called red flags. And I'm going to talk a bit more about what red flags are in the next slide. And they should have some basic tests to make sure that other conditions are not present. The NICE guidance, which are the UK kind of guidance body, do suggest that a number of tests shouldn't be indicated as first-line tests. Not everybody would agree with that, but in general, I'll go through that and discuss perhaps some of the controversies. So negative testing is important before anybody receives the diagnosis. In short, what is irritable bowel syndrome? Essentially, it's a disorder of the interaction between the brain, the gut and its nervous system, because there are actually more nerves in the gut than there are in the brain, and the microbiome and the wider environment with which we all interact. I'll talk a bit more about that in the next video about how irritable bowel syndrome comes about. But essentially, it's very often a multifactorial trigger, a multifactorial condition, where a number of different factors may bring about or trigger disease or relapse of disease. So in terms of red flags, so these are symptoms which or signs which raise some cause for alarm in healthcare professionals. Many people may have some of those red flags, but provided they are accounted for, and there's an explanation for them, that doesn't mean you can't have the diagnosis of irritable bowel, but I think they need to be accounted for. So in terms of what are red flags, unexplained weight loss. Clearly, if you go on a diet and you lose weight, that's fine. But if you've got unexplained weight loss, that's a cause for concern. Rectal bleeding. Now, rectal bleeding is not a part of irritable bowel syndrome, but it is relatively common. So 15 out of every 100 of us will have rectal bleeding in any given year. And some of us might have a little bit of bleeding on the tissue paper, and that might relate to an anal cause such as hemorrhoids, or might have blood mixed with the stool, which the stool might then be loose or might be solid, and that may mean different things. And it may be a one-off or it may be persistent, but rectal bleeding certainly requires consideration of further investigation. A family history of colorectal or ovarian cancer is a concern, but colorectal cancer is relatively common, so if you have 10 relatives, it wouldn't be unusual for you to have at least one relative with colorectal cancer. Healthcare professionals get particularly concerned if that relative is a first-degree relative, so that means a brother, a sister, a mother or a father, and if they develop disease under the age of 50, because that implies there may be a genetic or a stronger genetic component to it. That requires consideration if that is the case. Onset of symptoms of irritable bowel is unusual for the first time in people over the age of 60. And so in people developing symptoms later in life, that also requires more heed to investigation, particularly in the context that very often people at that time of life are more prone to other conditions as well. Similarly, anemia is not a normal thing in irritable bowel syndrome. It's not part of the diagnosis. And if you have anemia, you need to have that investigated and have it accounted for as to why that is the case. Likewise, if you have abdominal or rectal masses, lumps or bumps that you can feel, that requires explanation outside of the diagnosis of irritable bowel syndrome. So in terms of investigation, anybody, before they receive a diagnosis of irritable bowel syndrome, should have normal full blood count, that's a test to exclude anemia. They should have negative celiac serology. Now, essentially, that's a blood test to rule out a condition called celiac disease, which is where people develop an allergy to a particular component of a particular protein within wheat. Now, wheat is very widespread in our diets, so that's an important diagnosis to make, and it's managed through dietary intervention largely. I'll talk about that in other videos. They should have normal inflammatory markers. Now, conventionally, people have measured inflammatory markers in blood tests, but these days I think it's a reasonable expectation for people to have a fecal calprotectin, which is a marker of the amount of inflammation in the gut, and is a test on the stool. The NICE guidance says that the following tests are not necessary to confirm the diagnosis in people who meet the diagnostic criteria, in other words, who have a good story and an otherwise negative testing, as we've outlined in the previous slide. So it says that ultrasound, rigid or flexible sigmoidoscopy, colonoscopy, and barium enema. Barium enema is a test that very, very few people ever do these days. Thyroid function tests, examination of the stool for other parasites, fecal occult blood, or a breath test to look for either lactose intolerance or bacterial overgrowth, or CCAT testing, which is a test looking for bile salt malabsorption, which drives diarrhea, are not indicated in the initial diagnosis of irritable bowel syndrome. Not everybody would agree with that, and certainly in people that don't respond, consideration should be given to these particular tests, and I'll talk a little bit more about this. So breath testing might be to look for lactose intolerance, but it might also be looking for overgrowth of bacteria in the small bowel. Now, it's normal to have trillions of bacteria in your large bowel. You shouldn't really have very many bacteria in your small bowel. If you get bacteria in the small bowel, they can cause all sorts of symptoms, including bloating, discomfort, abdominal pain, and change in bowel habit. Often people have predispositions to bacterial overgrowth. Some physicians would argue for breath testing at an earlier stage, but in general, the NICE guidance would say treat people with irritable bowel syndrome initially, and if they don't respond, then consider breath testing. Similarly, in people with diarrhea predominant symptoms who don't respond to initial therapy, bile salt malabsorption testing with a CCAT test, which does expose people to some radiation, which is obviously not without risk. Small, but there, should be considered. And in people where they have persistent diarrhea that doesn't respond to initial treatment, even if they have a normal calprotectin, colonic biopsies are sometimes indicated, and that's to look for a thing called microscopic colitis. Now, that's a condition which is much commoner, roughly 10 or 20 times more common in women, particularly in those over the age of 50. So those are all considerations. The current guidance suggests that they should be considered only in those who don't respond to initial treatment, although I would accept that that is not universally agreed. So that concludes how to make the diagnosis of irritable bowel syndrome. The history is the most important thing, but negative testing is also really important in terms of excluding anemia and celiac disease. In my next video, I'm going to talk about how irritable bowel syndrome comes about, otherwise known as the pathogenesis. I hope you found this video useful and informative, and thank you for listening.